Here is the question. Yes. So if you have read and understood, let's begin our session. Can you please identify the following structures from A to G, H?
Okay. As is superior to
Ascending A is ascending aorta. Okay. B is
Okay. B is an auricle of the right atrium.
very good. C
B is the
pectinate muscle
vestibular
on the
system of the ventricular
yes
wall.
on right ventricular wall. Yes. D
This is the quadrate in the name.
caudate tendon. Yes. E
E is the pulmonary trunk.
yes. F
F is the auricle of the left atrium.
very good.
G is
G
the anterior interventricular artery.
yes. And H
Anterior inter H is the papillary muscle.
very good. Very good. Okay. Can you please tell me the layers of pericardium?
Okay. There is the fibrous and serous layer. The serous is also divided into parietal and visceral layer.
Yes. So what are their functions?
The pericardium it is contain pericardial fluid,
Yes.
act as shock absorber of blood.
Okay. Can you please tell me the function of papillary muscle?
Papillary muscle inhibit prolapse of the interventricular valve during ventricular systole.
Okay. Can you please tell me what are the structures which are likely to be damaged while doing pericardiocentesis?
That is two
Like in
main
the
layer.
subcostal approach,
Skin.
yes,
Okay, first there is the skin, and then there is the facial and the fascia.
yes, and then
The, there is the endothorax fascia,
yes.
and then there is the fibrous layer, the pericardium. Then there is the parietal layer of the pericardium.
Okay, there are different approaches, right? In which approach
Yes.
you are telling me which organ is susceptible to be injured? Like in
Uh,
parasternal approach and subcostal approach
Parasternal is the subcostal. Most likely
is
organ
liver,
damage is the liver.
yes, and
Yes.
in parasternal
And
approach,
parasternal will be the atrial or the ventricular wall with the coronary artery
both lungs can be punctured,
and the
and
lung.
as a whole, both of these procedures can cause damage to what?
The atrial or ventricular wall and the coronary artery.
Okay, and coronary arteries and atrial and ventricular walls. Yes, very good. Okay, can you please tell me what is the function and composition of the foramen ovale?
Foramen ovale is the transmit the repeat of the clot from the right atrium to the left atrium.
Okay, and what percentage of blood adult has anatomically patent foramen ovale?
10%.
Okay, what are the structures that ductus arteriosus connects to in fetus?
Connected to the pulmonary trunk and the descending thoracic aorta.
And where is the commonest site for coarctation of aorta?
Just distant to the left of major artery.
Okay, what do the bulbus cordis and truncus arteriosus gives rise to in adults?
The bulbous cord is gives rise to
Primitive ventricle.
the ventricle.
Yes,
Yes.
and
And the cranial part of the bulbous cortex gives
yes,
rise to the
and truncus
coronary artery
yes,
and
and
pulmonary
truncus
trunk.
arteriosus to aorta and pulmonary trunk. Okay, can you please identify the structures here? 9.
This is the pulmonary trunk.
Okay, structure 9 is pulmonary trunk. Yes, and 7, please.
This is the infundibular of the right.
Yes, very good. Number 1 here.
This is the chordating vein.
Okay, anterior cusp of tricuspid valve. Okay, number 5 here. Can you see number 5?
5 is the chordating vein.
Choroidal. Yes, 2, please.
2 this is the papillary vessel.
Can you tell me the blood supply of the
The
heart?
papillary
Which vessel is this? Which vessel is
this is
this?
the great cardiac vein.
Yes,
7 this is the great cardiac vein. 2 this is the anterior descending interstitial artery.
yes. Can you please tell me the blood supply of the heart?
It arises from the ascending aorta, the right and the left coronary
Yes.
artery. The right coronary artery gives rise to the vaginal artery, and the left coronary artery gives rise to the left circumflex artery and the anterior interventricular artery.
Can you please tell me how many borders does the
The,
heart have?
the right border is mainly
Yes.
formed by the right atrium,
Okay.
and the left border is mainly by the left ventricle.
Yes.
The inferior border by the right ventricle.
Yes. And a small part of left ventricle. Okay. And right. And and how many surfaces does the heart has?
Anterior sepsis, posterior sepsis, and the base.
Okay. Can you please identify these structures from 1 to 7 and 9? 1 is here. It's heart, but it's
This is the
rotating
right
kind of.
atrium,
Yes.
right atrium.
Yes. And next one. 1 is right atrium.
Two
What
is
is 2?
yes, two is right ventricle,
Yes. 3.
and
Where is
3 is
3?
the left ventricle.
3 is here. Yes.
The left
Right.
ventricle, and
And 4.
4 is the left atrium.
4 is pulmonary trunk. 5.
5 is the ascending aorta.
Yes. 6, please.
4 is the pulmonary trunk.
6. 6 is here.
This is the superior cava.
Okay. And right. And then 7.
7 is the pulmonary
Brachio.
ventricular trunk.
Yes. And then 8
Yes.
and 9. 8
9
is
is the
left subclavian.
the, the
And
subclavian
yes.
artery.
And 8 is left common carotid. Okay, can you please identify, there are other structures as well. From A, look, this, from A to F, there are structures. This is A here. Can you
A, this
identify?
is the right coronary artery.
Yes. And then this is B. It's
third sinus.
left coronary artery. And then we have C here.
This is the left circumflex
Yes.
artery.
And then D.
The anterior interventricular artery.
Yes, very good. And then E is here, pointing at
The
another vessel.
marginal artery.
Yes.
The marginal artery.
Yes. And then we have F, which is on the posterior surface. That's why it's dotted.
Posterior interventricular artery.
Yes. And then we have G as well here. G. It's also on the other side. So posterior circumflex artery. Okay. Can you please tell me what are the origins of right coronary artery and left coronary artery?
The right coronary artery lies anterior to the aortic sinus, while the left is posterior to the aortic sinus.
Okay, what is this structure V? It's pointing at something here. Some dot.
Cardiac vein.
Anterior cardiac veins, yes. What other structures drain? Yes. What other related structures drain the heart?
The middle cardiac vein, the great
Yes.
cardiac vein, and the anterior cardiac vein.
Yes. Great cardiac vein and middle cardiac veins. Okay. Can you tell me what is the surface anatomy of the heart?
Means the border.
Like from where to where it extends? This is the surface anatomy. So it's approximately size and shape of a closed fist, and it sits directly on the diaphragm without parietal pleura inferiorly. So surface anatomy, this is on the superiorly, like it's left parasternal at the second rib. On the right, it's right parasternal from third to sixth rib. And then cardiac apex, it's left fifth intercostal space mid-clavicular line. And then on the left, it's the line drawn from superior border of cardiac apex. All right, the last question you already told me. What are the coverings of the heart? So, all right, I think this is it. Thank you. Yes, yes, thank you. Bell even went.
Thank you.
Good, yes. What about, we haven't discussed the nerve supply of the heart. How is the heart? What are the nervous innervation of the heart?
By the vagus nerve,
Okay.
which gives rise to synovial nerve, then pass through the atrioventricular road,
Yes.
then through the bundle of.
Yes. Yes. This is the
Then goes
conduction.
through
Yes.
the Purkinje fiber.
Yes. Okay. Right. Thank you so much. Anyone else want to give feedback? No? It's good. Thank you. And here is the question. Right. If you have read and understood, kindly begin the examination.
Okay. After entering the room, I'll wash my hands and introduce myself to the patient,
Yes.
confirm the name and date of birth of the patient.
Yes.
Then I'll take permission from her to examine her by looking, feeling, and moving the arm and
Yes.
hand.
Yes.
And I'll request and help her for exposure of both upper limbs and chest area.
Yes.
I'll ask for saffron also to be present there, and I'll ask the patient to keep both the hands over the pillow, and then
Chevron
I'll
maybe is not
start.
required. Okay. Because it's, yeah,
Okay,
all right. Yes, please continue.
I just want to expose the upper chest area also,
Yes.
ma'am. So I just thought if because there is a female patient. Anyway, I'll start by taking a close look to patient's arms and
Yes.
hands for the fistula, and then I'll see for the site, size, safe surface, any scar mark and color of the fistula, and the character of the skin and presence of any ulcer or any gangrene or any uh, aneurysmal dilatation. I'll also look for any edema or venous collaterals over the chest or over the shoulder area. After that, I'll ask the patient I'll ask her about any pain at the shoulder, and if she needs any analgesics right now, then I'll provide for that. Then I'll take the permission for the arm elevation test.
Yes.
I'll elevate the arm to the level above the heart and
Yes.
look for the look at the fistula, if whether the fistula collapses or not. Normally the fistula will be collapsed, but in case of any venous stenosis, the distal part of the fistula will remain distended while proximal part will collapse. Then I'll ask the patient that I'll going to feel the arm. I'll just feel for the tenderness and see the patient's face for any grimace. Then I'll feel for temperature with the dorsum of my hand,
Yes.
and then I'll feel the radial pulse and the brachial pulse, radial and brachial pulses on both sides, and compare them. And then
What are the signs
I'll
of ischemia that you look for?
uh, in this case, in signs of ischemia, I look for the bluish coloration
Yes.
of the area, and
Paler or bluish? Good. And
it will be the mainly pallor, ma'am,
yes.
pallor.
Yes.
Uh, and there will
Anything
be
else?
pallor of the, and
Ulcers or
there will
gangrene?
be presence of the ulcer or gangrene if there is
Yes.
ischemic lesion.
Good. Yes.
Okay.
Next,
Uh,
please.
then I'll feel the pulsatility with the finger of my hand with along the length of the fistula, whether it is pulsatile or not. And then I'll feel the thrill using the palm of my hand. I'll see the both with the systolic component as well as diastolic component of the thrill. Then I'll do the skin pinch test. I'll catch the skin over the fistula, whether it can be catched or not. And in case of ischemia, it cannot be catched, and there is a chance of ulcer formation or rupture of the fistula. I'll also see the direction of the flow. I
Good.
occlude the fistula with the tip of the finger and palpate on either side of the occlusion and see which side is the pulse, and that will be the opposite side will be the direction of the fistula. And then after that, I'll feel all the upper limb pulses, and if any of the pulse is not filled, then I'll use the handheld Doppler to see the pulse, and if see if any pulse is absent or not. Then I'll
How would you
do
rule
the
out if the fistula is stenosed or not?
uh, in case of there will be a stenosed fistula. In case of stenosed fistula, like first arm elevation test, in case of stenosed fistula, it will be only partially collapsed, not complete collapse. There will be proximal portion will be collapsed while the distal portion will remain
They'll
distended.
be
Uh,
thrill will be increased and localized
another
to the area of
yeah,
lesion,
another, yeah,
and
another
only in
the
systolic.
three.
Yes.
Yes, ma'am. In thrill, in case of stenosis also, the thrill will be increased on the digital side.
Yes, good.
Yeah, and another is that is the what we call the augmentation test.
Yes,
Yeah,
good,
augmentation test.
good.
When we'll occlude the fistula, a little distant from the arteriovenous anastomosis,
Good.
the arterial pulse or wrist will be increased or augmented.
Very good, yes.
But in case of stenosis, it will not be augmented.
Good.
Then I'll go to listen for the fistula.
Yes.
Over the fistula, look for any bruit. And normally, in normal working fistula, it will be low pitched sound. There will be
Yes.
soft and machinery like sound. And in case of stenosis,
Yes.
this bruit will be it means high pitch, and it will be only systolic component, while in normal case it will be both components.
All right.
Then
listen for the presence
after
of
that,
I'll
I'll thank the patient and remove the gel while I used in Doppler. If I used in Doppler, then have the patient to get dressed. And at last,
you
I'll
please,
wash my hands. And,
thank the patient. Now, can you please present your case?
To complete my examination, I would like to perform the neurovascular examination of upper limb and complete cardiovascular examination. Today, I have examined this 65-year-old lady who presented with right-sided, who is a known case of renal failure and presented with sudden bluish discoloration of her right hand and upper arm over the night. On examination, I felt that there is there is a thrill is increased on the area, and a skin pinch test, I don't know whether it is positive. And also the bruit over the area was augmented in systolic only. You cannot feel it in the diastolic.
Okay, so what are your main differential diagnosis?
My differential diagnosis will be that it is the dialysis ischemic steel syndrome.
Yes.
I'll also consider the another diagnosis, that is ischemic monomelic neuropathy, as my differentials.
Okay. How would you manage this patient?
First of all, after complete examination, I'll go for imaging using the arterial duplex study.
Good.
After that, I'll discuss the case with my consultant, and the treatment option for the patient will be the first will be the restriction of the fistula flow by using the banding or by surgical revision through which we can restrict the fistula flow. Or if the fistula cannot be recovered, then we can ligate that fistula, and then we can create another fistula either in the same arm more proximally, or if not possible, then we can use the contralateral arm.
Very good. All right. Can you tell me the differences between dialysis ischemic steel syndrome and ischemic monomelic neuropathy?
Ma'am, in dialysis ischemic steel syndrome, hands are usually pale or cyanosed, and it is cool, and the radial pulse will be diminished or absent, and the augmentation test will be positive. That is on fistula compression, the distal pulse will be augmented, and there will also be, if there is any pain, there will be relief of the pain.
Very good.
While in the ischemic monomelic neuropathy, it is usually due to the ischemia of the nerve of the hand, and it doesn't involve the other tissue, so there will be paresthesia and numbness of the hand, and there will be motor weakness, as well as there may be paralysis of the hand, or
very good.
Like if radial nerve involvement, then poor wrist extension will be there. If ulnar nerve involvement, then will be intrinsic hand muscles will be involved, and in case of median nerve, thumb movement will be involved, especially opposition of thumb will be involved.
Very good. And hand will be warm.
Yeah, hand will be warm and there will be normally
Radial.
palpable radial pulse.
Very good. Okay,
Yes.
good. Audible Doppler signal will be present. Very good. Okay, good. Excellent. Thank
Yeah,
you.
if I will do the Doppler, there will be audible Doppler signal. Yes.
Very good. Excellent.
Thank you, ma'am.
Yes. Anyone else want to give feedback? Thank you. I'm starting the timer. Yes. Let's, yes, begin. Right. Too much to read. Right. If you have read and understood, kindly please tell me what is your provisional diagnosis?
So it may be aortic stenosis.
Very good. Can you please tell me the pathophysiology of aortic stenosis?
Yes, aortic stenosis can be either congenital or it may be secondary to rheumatic fever or in old age due to
Pathophysiology. Those are the causes. What happens? There is
pathophysiology.
valve obstruction that leads to
Yes, so in congenital or in any kind, there is disturbed blood flow leading to the valvular endothelium damage, uh, resulting in inflammation, fibrosis, calcification, and then stenosis, resulting in fish mouth deformity of
there is
the
increased intraventricular pressure to maintain cardiac output that
and
leads
resulting
to
in hypertrophy
ventricular wall,
and
yes, hypertrophy. This leads to left
decreased
ventricular
perfusion,
hypertrophy and decreased compliance, impaired passive filling, increased preload.
decreased pulse pressure,
Yes.
and
Ultimately, what happens
hypertrophy
at the end? At the end, there is angina, syncope, dyspnea. These are the presentation because of increased filling pressure, ventricular dilatation, contractile dysfunction, and ischemia and arrhythmia. Okay, now please tell me the causes of aortic stenosis.
So it may be either congenital, like uh, by cuspid valves, in which as the child grows up, then there will
Okay.
be
One
high
is
peak.
congenital. Number two, quickly, you're not going to
Second
get
is
so much
rheumatic
time.
fever.
Could be, okay, rheumatic,
With
post-inflammatory type. And the third, aging,
third one is
calcification.
calcification.
Yes, now please tell me the mechanism. How does the stenosis occur? What happens?
So
There
there is
is
turbulence of blood
lipid
flow.
accumulation, yes,
Yes,
and
turbulence flow,
yes,
accumulation of the lipid, trauma formation,
yes,
and then also fibrosis, inflammation, and stenosis of the valvular area. And there is also vegetations, infection,
yes,
chances of
yes.
infective endocarditis leading
If
to
it is
infection, thrombus,
infective type, yes.
that can lead to MI and also stroke or other complications.
Which coagulation system is affected? Is there any?
So it will be basically extrinsic first, intrinsic,
Yes,
in which factor 12 leading to activation of factor 11, 9, and then 10,
okay.
resulting in activation, which is due to,
Intrinsic, okay.
uh, exposure of the platelets to the subendothelial collagen, resulting in release of ADP, serotonin, and thromboxane 2, which leads to further aggregation and further activation of the platelets. formation of thrombus and thrombin.
All right. There is a classic triad for the diagnosis of aortic stenosis. Can you please tell me what that is?
Diagnosis. Okay, so
Of
there will
aortic
be
stenosis, yes.
displaced apex beat and left ventricular hypertrophy, in which the leads V1 and
I'm asking for
V2,
your
they will be,
symptoms of aortic stenosis, in other simple words.
okay, syncope,
Yes,
decreased pulse pressure, syncope, and angina.
chest pain,
And
okay.
abduction.
Yes, good. And what are the signs of aortic stenosis?
So it will be early systolic murmur radiating to the carotid area and accentuated on leaning forward. And
Okay.
also the basal crepitations of the
How would you
chest due
explain
to
Gallop
convulsion.
murmur, S4 Gallop, which this patient has?
I'm sorry.
S4 Gallop, how would you
sorry.
describe it? Okay. What are the complications of aortic
can't.
stenosis? What are the complications of aortic stenosis?
So it can lead to arrhythmias, ventricular tachycardia, and MI, angina, syncope, stroke,
Pulmonary edema,
congestive heart failure.
yes. Cardiac arrest,
Pulmonary edema,
yes. All right. Okay. Can you
Syncope.
please help me to read this ECG? What do you see?
Mhm.
What does it signify?
Okay.
Yes.
Well, I can't see it much clearly, but roughly I can say that the rate and rhythm, they are okay.
It's little blurred, but
QRS is a bit higher,
yes.
and the QRS complex is also wider, and T wave inversion is seen
Okay.
in lead 1 and 2, and lead lead 1 and well, I cannot comment more than this
Okay.
for the moment. While the rate,
What
maybe I can't see the
investigations would you do to
doctors.
confirm your diagnosis?
Mhm. For this aortic stenosis, okay.
Yes.
I'll do the echocardiography, ECG echocardiography, and well, only
Any blood tests that will help you to rule out?
since I think they are enough.
Okay. How would you
And
grade
I'll
aortic
look for.
stenosis? Is there any way
So
you
it will
can?
be mild, moderate, or severe.
Okay.
Yes,
How do
depending
you
upon
grade
the
them?
depending upon the valvular area. If it is more than 3.5 centimeters square, it's okay. If it is between 2.5 and 3.5 centimeters square, it's mild, and between 1.5 and 2.5, it is moderate, and below 1.5 centimeters square, it is severe aortic stenosis.
Okay. Can you tell me if it's possible that because of the presence of circulating cardiac troponin 1, you can detect if patient is having aortic stenosis or not? Is it by any chance related to aortic stenosis?
If it
Okay.
results in the MI, then
Left
it can
ventricle
lead
dysfunction.
to release of
Okay.
troponin in tropi.
Can you please tell me few causes of decreased diastolic perfusion? Few causes which leads to decreased diastolic perfusion. Yes.
Okay, in this case, left ventricular hypertrophy. As we know, cardiac perfusion is during the diastole. So when the tachycardia, there is tachycardia, the perfusion is decreased, and when there
Good.
is increased intraventricular hypertrophy and pressure,
So
then
what are the
during the
things that
diastolic
lead to tachycardia?
yes, and so tachycardia can be increased due to sepsis,
Yes. Very good.
hypovolemia, hemorrhagic shock, or even pain
Yes.
or sympathetic stimulation.
Even some drugs as well. Very good. Bell has gone and you were still talking. Why? What happened? Okay, just let me go through if I have covered all the questions, please. Very good. Okay. If we can maybe tell you that in this ECG, you'll be seeing left ventricular hypertrophy and repolarization abnormality, but there's acute ST and T changes, which are suggestive of myocardial injury as well. Not though clear, but still, it, yeah, good,
There is
thank
TVL
you.
there.
I'll show you, it was the article, I had it somewhere, yes, here. Yes, this is from this article, and this is what it says. If you want, maybe I can and try to enlarge it. Can't more than this. But it's not clear, but that's how it is. I got this from this article. No, can't enlarge any further. All right, good. Thank you. Okay, and here is the timer. Here is the question. Right, if you have read and understood, kindly begin your history taking.
Hello. Hi, my
Hello,
name is Dr. Zara. I'm one of the surgical doctors. Can I confirm your name and date of birth, please?
I'm Jane. I'm 54
Hi, Jane.
years.
Nice to meet you. Um,
Nice to
I
meet you,
understand you are
doctor.
having some trouble with your back pain. Is that correct?
Yes, actually, you're right. I've been having this pain for a long time now, and it's getting worse since the last 3 years. So that's why I've come to you today.
Where about do you feel this back pain? Is it in your upper back or the lower back or somewhere in the middle?
It's in the lower back, and this pain has been there constantly for quite some time now. It's become like my old friend, but the pain is now really disturbing me. You see, I have to work to look after my husband, and also it's becoming very, very difficult for me to now go to work. So that's why I would like some treatment for this.
Sure, sure. I'm sure we can do something for you. Tell me more about this pain. Where about in your lower back is it? Is it in the middle or is it more towards one side?
It's in the middle, actually.
And
But sometimes it goes here and there.
okay, does it come down
Yes.
towards your legs?
Occasionally it does.
And which leg is the worst one? Is it the right one or the left?
Both of them. Actually, I cannot identify.
Okay. And does it come down your thighs towards your calf?
Sometimes it does, but most of the time it just stays there.
Most of the time it just stays. So it just stops at the knee mostly.
It does, yes.
Okay. Do you feel, if I ask you to rank this pain out of 10 from 1 to 10 and 10 being the highest, what would you think of it is?
Initially, it was a 5 or 6, but now I would say that it's increasing to 7, 8. Right now, I would say it's an 8 because I'm actually in a lot of pain.
Okay. And you said it's constant.
It's increasing, but yes, the pain is there all the time.
And have you tried any pain relief in terms of any medications or any other therapy?
Yes, sometimes I do take painkillers that my previous doctor had prescribed, and it ails for a while and then it again returns.
Okay. And do you think the pain gets any better if you're bending forward?
No, I can't really say anything like
Any
that. I haven't noticed.
particular movements you notice that pain gets worse?
Um, no, I just know that it gets worse as I'm working,
And what do you do
and
for
then
this work?
it relieves. Then I have to stop, take some rest. Sometimes I lie down on the bed, and I have to take. Sometimes it's so painful. I have to take some days off from work. So you see, that's not really good for me.
I'm sorry about that. What do you do for your work?
Oh, I'm actually a teacher, a
Okay.
PE teacher.
Are you involved in too much of heavy lifting, or you do strenuous exercise a lot?
Yes. Not no, no, I don't.
You don't. Okay.
But you know the usual house chores and the bucket lifting and the water, and yes, it happens. I need to. You see, in my house, it's just me and my husband, and he's not been able to move about much since the last 6 years. So
I'm
yeah,
sorry about your husband. What kind of pain
all
is it?
right.
Is it like a sharp stabbing pain, or is it like a dull ache which is there all the time?
I would say a dull ache.
A dull ache. And you never had this pain before, like before 5 years, never had any surgeries or on your back.
No, I did not have any surgeries, but yeah, it's been there for 5 years.
And do you
I
think
don't recall having any even. Yeah.
how much you can walk before this pain just ask you to sit down, or it doesn't affect your walking?
Mm, maybe I could walk for around what 3 or 4 minutes, and then sorry, 15 minutes or so, and then it would start, and then within half an hour to 1 hour I'd have to stop.
Okay. And do you feel any pins and needles in your legs?
No.
Any numbness in your legs?
No, but I do feel weak
Whereabout do you feel weak?
in my hands and fingers
In your hands and fingers?
sometimes.
Okay.
Y-
Um.
yes.
Okay. And you don't have any trouble with your bowel or bladder?
No, no trouble
You
there.
never had any episodes or any incidences where you lost control of your bowel and bladder?
No, not so. No, no, not really.
Okay. And you don't feel any numbness in your private parts?
No.
Right. And do you have any other medical problems?
Mm, no, doctor.
And you're apart from your regular pain medications, you do not take any other pain relief.
No, I don't.
And do you have any allergies?
Not that I know of.
Okay. And any other in the family with the same trouble or with a history of cancers?
No, not that I know of. But yeah.
Okay. And you work as a teacher, you mentioned. And do you smoke?
No, I don't.
And how much? And have you ever smoked?
No, I don't smoke, doctor, and I haven't ever smoked either.
Okay. How much is your alcohol intake, if there is any?
Oh, very little to none actually. Don't
Okay.
get much time.
I think that's good. And how much? And you walk without any aid. You're comfortable with it.
Uh, Sometimes when the pain is very severe, I'd like to use a walking stick, but other than that, no, I'm quite fine.
Going back to the pain again, have you noticed any loss in your weight recently?
Uh, no, I haven't.
And have you noticed any incidences where this pain wake you up in the middle of the night?
No, no.
Okay. And no night sweats at night time.
No, I don't. No, it's not.
And
I haven't experienced such thing.
and your movements of your upper body, you don't feel the pain gets worse.
No, no, doctor.
Right. Is there anything else you want to add on which I didn't ask and you want me to be aware of?
No,
I discussed
yes,
eyes,
actually, 4
idea,
years
concern,
ago,
and expectation. Yes.
for 4 years ago, I had done a test, an MRI, I guess, which showed that there are some problems in my spine. So, yeah.
Right. And that was 4 years ago. What are you expecting? What are your
Yes, and
expectations from this clinic appointment today?
I would really love to get a solution for this severe backache. You see, it's quite debilitating my work. So, yeah.
Right. I understand. Obviously, it's been going on from last 3 years, and what we'll do is after this history, we'll probably need another scan. I will examine you, and we'll get another scan, and we'll find out the cause for your back pain. Okay. Thank you so much for your help.
All right.
We'll get back to you as soon as I can.
Thank you, doctor. Thank you.
Can you summarize your case now?
Right, so I've been asked to take a history from 54 years old Jean, who has been having trouble with her back pain from last 3 years. The
5
pain
years. Yes.
from last 5 years, but it got worse in the last 3 years.
Yes.
She has pain more localized in the middle of her lower back, but it does radiate down to her legs up to her knees and intermittently to her calf as well. She reports no neurosensory deficit, but she does feel weakness in her hands. She reports no bowel bladder symptoms, no numbness in her private parts, no other red flag symptoms for cauda syndrome. She reports no other red flag symptoms for malignancy. She's otherwise fit and well and is not on any medications. She does take some pain relief for her back pain, which gives her temporary relief. She has a
So,
claudication distance of around 15 minutes, and after that, she sits down. She does not walk
good.
with an aid and has a husband who she looks after.
So, what are your differential diagnoses?
My main concern is degenerative disc. My main differential will be degenerative disc disease, or it can be musculoskeletal, or it can be from a disc prolapse. Um,
Okay. How would you manage this patient further?
I would like to examine this patient from the neurological point of view, and this patient
Yes.
needs an MRI scan.
Any other exam investigation you want to
I didn't ask about the trauma, which
ask
I should
further?
have.
Yeah.
But in that case, she will need a X-ray as well, and I would like to do some basic blood investigations like FPC, UNEs, and clotting profile, and electrolytes.
If you suspect any trauma and there is any suspicion of crush fracture, which scan or images would you
I'll go
depend
for
on or would
CT
you ask for? Sorry?
scan.
DEXA scan or CT scan. Okay.
DEXA scan.
Yes. How would you manage this patient?
From the management point of view, I will perform the full examination and then I will repeat some blood investigations and will ask for a plain uh, lumbar spine X-ray followed by MRI scan.
Yes.
And depending on the MRI report, I will start this patient on neuropathic pain medications and then manage her pain according to the MRI scan.
If patient presented with any cord compression symptoms, what would they have been? What are the red flag symptoms you would have?
The red flag symptoms for cord compression would be
Yes.
back pain coming down both legs, bilateral pins and needles of anesthesia, bowel or bladder incontinent episodes,
Yes.
sudden anesthesia, and sexual dysfunction.
Okay. Good. And this age of onset as well.
Sorry?
Less than 20 or greater than
Acute
50.
onset.
So age, yeah. Okay, good. So if it was cauda syndrome, what would have been the management?
So that depends on where I am and how are the spinal services in my hospital. But if
Yes.
we have the spinal service available, the patient needs urgent surgical decompression as soon as possible, ideally within 24 hours. But if we don't have a spinal service, then she needs to be referred to the a hospital with the spinal center.
Very good. Okay, good. And then they'll be referred to the social worker as well. Maybe in this case as well, we can, because she can't take care of her husband as well and her own self. So good. Now my own, the only concern is the time. You took at least 2 minutes extra. So we'll practice more. And there was one, did you ask how the pain started? The onset, how it started?
Yeah, I didn't ask the answer. I think I started
Yeah,
5 years
that
ago.
because when discussing pain, after you asked the patient to localize the pain, then you could have asked how the pain started, how the onset occurred. Yeah, then it would have covered the trauma if patient come across any trauma or not. Character you covered afterwards. And right. And yes, one more question you can add in your history. If the patient, when the patient wakes up in the morning, she experiences any stiffness of the back. So that will rule out any inflammatory cause.
Okay.
Yeah. What else? Yeah, you kind of asked exacerbating and relieving factors. So that was kind of covered. Yeah. Anyone else want to give feedback? Otherwise, it
Yes,
was good. Yes, please. Yes, please.
yes. Firstly, is she do it perfect, really,
Yeah.
and her voice is clear and confident.
Yes.
But I'm wondering if she couldn't repeat the question again in another way. She asked about smoking, and patient said she is smoking, and ask again about smoking, and ask about the pain during walking, and patient explain that and return back and ask about walking and using aid, and ask about numb or pain and numbness
Yeah.
two times. And there is no time for all this question in just
No.
6 minutes. Yeah,
Yeah.
just one question. If even the patient answer the question,
Yeah.
uh, mm, you don't need to ask again the same question.
Yeah. Or like if
Another,
you want to get the answer, then rephrase your sentence, like you
yeah,
said. Yeah.
yeah. But sometimes patient give you more information from the first talk. When you
Yeah.
ask him, you could explain. Don't ask him again the
The same
question
question.
he
Yes.
already answered.
Yeah.
Another thing, when she answered the management, she already answered before the investigation she required.
Yeah.
The management already goes to the treatment immediately because you already mentioned investigation, X-ray, MRI, and DEXA scan, and others.
Yes.
Yeah,
Good.
when the next question was the management, just say I need to consult spinal surgeon or orthopedic surgeon. It maybe need conservative management or surgical management according to the result of his investigation.
Yeah. Good. Yes.
Yeah.
This will save time as well.
But on the other hand, really, she is a confident. Her
She's
voice is
confident.
clear, and she asked everything.
Yeah. Yeah.
Yes, thank you.
Thank you so much. Yes. Good. Good feedback. Yes. Anyone else want to add anything? Yes. Good. Thank you, everyone. Thank you, Dr. Vajia.